Hello and welcome to today's Center for Healthcare Strategies webinar, The Road to Accountability, Promising Practices to Foster Meaningful Health System and Community Partnerships, made possible through support from the Robert Wood Johnson Foundation. My name is Hadley Fitzgerald, Senior Program Officer from the Center for Healthcare Strategies, and I'm delighted to welcome you here today. We hope you enjoy today's event. At the end of today's webinar, a brief online evaluation will pop up on your screen, so we hope you will take a moment to complete that survey. On the next slide, you can see today's agenda. We'll start with introductions of today's facilitators, and then we'll hear a brief presentation on uncovering best practices for strengthening community partnership. After that, we'll be fortunate to hear from several wonderful panelists on health system strategies for building accountability to communities. And this panel will be followed by a Q&A where we will take questions submitted by the audience. Speaking of questions, on the next slide, you can see how to submit one at any point during the session by clicking on the Q&A icon located at the bottom of the screen. We will gather these questions and respond to them during the moderated Q&A discussion towards the end of today's session. So to get us started, I would like to introduce a little background about the project behind today's session, the Activation Project. It stems off a multi-year initiative that some of you may be familiar with called Advancing Integrated Care, or AIM for short. That was led by Center for Healthcare Strategies and also with support from the Robert Wood Johnson Foundation, and it focused on implementing person-centered integrated care models, such as trauma-informed care and complex care management. And lessons from that project pointed towards the need for health systems to more meaningfully engage with their patients and the communities that they serve, and even more so the need for health systems to have greater accountability and shared decision-making. So to unpack this, we conducted a literature review as well as stakeholder interviews in partnership with Center for Health and Justice Transformation, who joins us today. And on the next slide, you will see that we are joined by my colleague, Zakia Grant-Knight, Program Officer at the Center for Healthcare Strategies, who will be giving an overview of our project findings in just a moment. And unfortunately, Sarah Martino, Deputy Director of Center for Health and Justice Transformation, was unable to attend, but we are very lucky to be joined instead by her colleague, Zach Gross, who is a project coordinator at CHCS, and he will be leading today's panel discussion. So for those of you not yet familiar with the Center for Healthcare Strategies, or CHCS, we are a policy design and implementation partner, and we work with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults served by the Medicaid program, and for services that help address health-related social needs. And on the next slide, I'm pleased to share some introductory information about our partner, Center for Health and Justice Transformation, who we've had the chance to co-create this project with. CHCS is a nonpartisan organization whose mission is to advance health equity in the criminal justice system. And you can read more about their mission on this slide. All right, so I will now pass it to Zakia, who will share some of our project findings.
Thank you, Hadley. As Hadley shared earlier, this work helped us understand how health systems and communities can be more collaborative and work in partnership to drive health equity through a literature review and stakeholder interviews. We interviewed 9 safety net health system leaders, 5 community-based organization leaders or community representatives who were currently in a partnership with the health system, and 11 subject matter experts on health equity, racial equity, accountability, and culture change within organizations, health systems, and community partnerships. Next slide, please. When talking about accountability, 2 terms come to mind: power, the ability to direct or influence outcomes, and community, a group of people with a common characteristic or interest living together within a larger society. We use these definitions that came out of the literature to guide our conversation, like when we ask health systems how the community has been able to influence outcomes in their institution. And we acknowledge that in different contexts, community might refer to the health system's patient population or to the geographic community in which the health system is based, or it might just refer to a specific demographic or racial and ethnic group whose outcomes the health system is particularly concerned with. Health system leaders also emphasize the importance of being considerate of how their staff is reflective of the community as well. Health systems who want to more meaningfully partner with community need to reflect on the power imbalance. Institutions have historically set the health agenda and taken up space in the community without much meaningful input from community members. We found that when it comes to accountability, one of our interviewees described it well: a presumption that there's a shared understanding of expectations and a desire to meet those expectations and take responsibility. Next slide, please. Many of the health systems we spoke with are increasingly focused on opportunities to achieve greater health equity. By valuing relationships with community partners and actively encouraging community involvement, health systems can better understand community member needs and design more responsive approaches to reduce health disparities, drive better health outcomes, and decrease costs. Community partnerships are a mechanism for achieving health equity. We have found, though, that there is room for growth within this approach. Next slide, please. Here are some core principles we heard from health system representatives and community leaders on how health systems can build relationships with community. Acknowledge harm. This is an opportunity for institutions to take responsibility for harms they have caused communities in the past, which may relate to present health inequities, such as structural racism. Establish community partnership mission. Allowing community partnership to be a part of the mission allows for greater intentionality and focus for the organizations, with less one-off programs and initiatives. Commit for the long haul. We heard from everyone, community members and health systems alike, that this process of change takes a long time, and success can't be evaluated in the same way because of the amount of time it may take to show results. Practice radical transparency. Be honest about what you can and can't do helps create realistic expectations. Build relationships across the continuum. There are various types and ways to partner, and be open to those possibilities. Next slide, please. As I mentioned, building relationships across the continuum is a core principle in partnering with community. We came across many different examples of continuums in the literature review, but here is one example we found that was created by the group Facilitating Power. We found them to be a very helpful way for organizations to think about this work. This can be a tool that organizations wanting to make change can use to see potential next steps in the process to more meaningful partnership. It starts on the left at stage 0, in which is ignore, where a health system is doing nothing to partner with the community. In the middle is where we found many health systems, in the consultation stage. One example of this is patient and family advisory councils, where patients lend ideas to hospitals. But lacking in this stage is a guarantee or commitment to take that input and then do something with it. As I said before, in order to achieve health equity, partnership is a potential mechanism, and that can be seen on the right end of the continuum, actually giving community members decision-making power. We did find some examples of this. We heard from some health systems that they hired community members to conduct and analyze the community health needs assessment, which we can see as the collaboration stage. And then they took it to the next stage of deferring to by allowing the community to guide and make decisions about program planning based on the results of the community health needs assessment. Moving along the continuum is a process, and we acknowledge that the process doesn't happen overnight. I will now turn it over to Zach to lead our panelists, who will share other examples of what partnership in action can look like.
Thanks, Akia. So I'm happy to be here and fill in for my colleague Sarah today. And it's so nice to get a chance to connect with our partners at CHCS again and to see our panelists once again. We have such an impressive panel here, so I thank you all for making time to be with us. I don't want to shortchange anyone's accomplishments, so I will introduce each panelist and run through their bios as quickly as I can. So we have Whitney Buchman, who is founder of Illustra Impact. She brings a global MBA and over 12 years of experience facilitating collaborative innovation with a specialty in authentic community engagement, driving systems change, and leadership development. Her results include changes to state legislation and Medicaid contracting in New Jersey, a thriving national health equity program and social enterprise run by the Camden Coalition, and racial justice investment recommendations from the international stakeholders of a community organizing network. Whitney's work in Camden, New Jersey, organizing for change to the non-emergency Medicaid transportation system, leading community and consumer engagement programs in the complex care ecosystem, launching a National Consumer Voices Bureau, and standing up a collective impact initiative to address food insecurity as a leading social determinant of health has shaped her perspective on health systems accountability to communities. Thanks, Whitney, for being here. Karen McIntyre is the Vice President of Workforce for South Central Foundation, which she joined in 1996. She plays a key supporting role in strategic planning and development. Karen is responsible for the development and management of human resources, policies, programs, and procedures related to recruitment and employment, compensation and benefits, employee relations, human resources, information systems, safety and training, and other associated programs. Karen played a key role in the application that led South Central Foundation to become a Baldrige Award-winning organization. Karen is of Yupik Unangan descent. She presents nationally and internationally on whole system improvement, customer focus, workforce improvement, innovation, and South Central Foundation's NUCA systems of care. Dr. Dan Swayze is the Vice President of Community Services for the UPMC Health Plan and has more than 30 years of healthcare and public safety experience. He currently oversees a multidisciplinary team of more than 100 community health workers, community paramedics, nurses, and social workers providing in-home and community-based intensive care management services. Previously, he served as the Chief Operating Officer of the Center for Emergency Medicine, where he received several regional, state, and national awards for his role as a pioneer in the emerging field of community paramedicine. And I believe our fourth panelist is unable to join us, but we've had great input from Imam Sharif Muhammad on this project so far. So now we'll move on to questions. We have prepared 3 questions for each panelist, and just so that we can really dig in and get through as many questions as we can in the 45 minutes. I'll ask each panelist their first question and then cycle back through to the second questions for each panelist and so on. So Karen, I will start with you, lucky you. So could you talk about the history of the South Central NUCA system of care and why accountability to community was really baked into the system structure since its inception? Oh, I think you're muted, Karen.
Thank you for having us, and thank you for the opportunity to share part of South Central Foundation's story. As part of our history, we're a nonprofit tribal health organization located in Anchorage, Alaska. We have over 65,000 what we call customer owners, and serve over 55 villages in rural Alaska. And as part of South Central Foundation's history, the services were previously provided by the Indian Health Service and the government. And during that time, our community was denied voice in how care was being provided. And We had employees that were unhappy. We had customers that were unhappy. There was no trust in the healthcare system associated with being able to receive quality care. And at the time, as part of our history, we knew that we were going to assume management and own and operate our own healthcare system and take on that responsibility to provide services to our grandmas and our aunties and our uncles. And we partnered with the Indian Health Service really early on in a first ever community-wide listening of what people wanted in their healthcare before we assumed management. And as part of that process, we heard from our community that they wanted to own and operate their own healthcare. They wanted to be in relationships with their primary care providers. They wanted clean facilities, and they didn't want to be, guinea pigs or tested on by new individuals who were coming into the healthcare. So as part of our history and knowing that, we knew that we had a big opportunity to change and to rebuild trust with the community. So at that time, we shared those results, and then we said what we were going to do about it. And we picked one thing to start with, and that was advanced access and being in relationship with your primary care provider.
Thanks, Karen. I've really loved getting the opportunity to learn about the NUCA system of care, and that transparency and the relationship building is just really great to learn about. So moving on to Whitney, your story kind of starts with you being a community organizer. And then you took those skills with you to your work at the Camden Coalition. What role do you think healthcare systems can or should play in community organizing?
Thanks, Zach. I think there's really three key ways in which health systems can play a role in community organizing. One of the first is that in order to do authentic community organizing, we want to be responsive to the community's needs and what arises. And oftentimes funding traditionally has been pretty restrictive. And so being partners in funding, especially through the community health investment, there's $25 billion in tax exemption at the local, federal, and state levels. And across the country, the 9 largest community organizing networks have an annual budget of $600 million. So, that's just a small portion of that tax exemption. So investing in community organizing in communities is one way. The other is collaboration, in the sense that I really think a beautiful example was when I was an organizer, I partnered with a local rehab facility who allowed me to come in, and they shared their books, their sign in and sign out sheets. Their social worker gave me her calendar and allowed me just to do an analysis of, we were studying the impacts of non-emergency Medicaid transportation. So they allowed me to see when people were coming in, when they were going out. A local doctor came to us and said, we are double booking because we have so many cancellations because of transportation. Here's how it's impacting us. We had the Camden Coalition at the time say, hey, we have a partnership with Medicaid. We're one of the few that can ask for data from them. Let us get the data and analyze it, and then let's together tell the story. So across those partnerships, we collaborated to go to Medicaid and the state together to end. So they also followed our lead. The other thing I would say is this amplifying and advocating alongside community leaders was another thing that they did. They said, we hear you and these stories are important. Let us support your stories through this data, through this sharing. We have these relationships. Let us help you get a meeting with the right decision makers, and let us lift up our voices behind what you're hearing on the ground. So it was that collaboration, that amplification and advocacy alongside community leaders that really I saw as a beautiful way to partner with health systems.
Great, thank you. I think that's really huge as well. Oftentimes there doesn't need to be a whole reinventing of the wheel. It's like there are community leaders doing great work. And so identifying those individuals and amplifying their voice is definitely something that we've seen in examples where there's successful collaboration. So thanks. Moving on to Dan. Healthcare decision-making is undoubtedly driven by financial constraints, to say the least. How do you start having conversations with healthcare leadership about that great thing we call ROI, that investment of building trust with community when it might take many years before there is a visible return?
Yeah, and I have a feeling that it's a great question and a pain point that's shared by many of us who are trying to answer that exact question. I can tell you at UPMC, we've benefited from somebody on our board actually asking a question that has really framed the discussions that we've had with the community. And that's to turn that around a little bit and said, well, what's the cost of the status quo? We all know that there are excess costs in the healthcare system now, driven in large part by the health disparities and health inequities that we see occur every day. In Pittsburgh, we had that dramatically emphasized in 2019 with a report that basically put Pittsburgh at the bottom of all of the cities in the United States when it came to the incidence of health disparities overall in many of the key clinical areas. And so we really had to take a hard look at ourselves and what we were doing there, in realizing that as expensive as the system is today, it is woefully inadequate for certain communities. And we need to do something differently and look at this. And you're absolutely right. This is really complicated math. It takes years to show any change in community behavior or individual behavior to produce this. And we know that those biggest opportunities lie in the communities that are impacted by health disparities overall. But I do want to just add real quick that Whitney's point is spot on and relevant to our experience in terms of how we can optimize some of the funding opportunities that are available to us so that it decreases the expense that we incur. And at UPMC, we leverage the heck out of all of those tax credit programs that allow us to invest in neighborhoods and communities in order to make the most of those investment opportunities and tax credits at the state level. We also look, quite frankly, to our philanthropic partners who are also concerned about these types of issues to say, we're at a pilot stage. We need some seed monies to be able to invest in this and really explore where those opportunities are down the line so that we know where to better make those investments overall. And a large part of that is, just to echo another point of hers, is that data sharing, whether it's sharing paper logs or databases full of information. What can we do to really get our hands wrapped around the prevalence of inequities and disparities? How can we better measure these things, knowing that we have constraints in the billing system data that we rely on most heavily, and then extracting information from an EMR system can be painful when you're looking at this. I think we're all at the early stages of that. So really leveraging all of those different tools that she emphasized is important in justifying and creating that ROI. But going back to my board member's comment, I think what we can all agree, even though this is new science, it's new to all of us, we're trying to figure this out. I don't think anybody has really come up with a template for us to do that ROI analysis on a national level. I think what we could all easily agree on is that what we have in place today is probably the most expensive and least effective way at addressing health disparities. And we just can't continue the status quo.
Thanks, Dan. Yeah, I think being really honest about the cost of the status quo is an essential starting place for a lot of these conversations. So circling back to Karen, given the amount of community representation at all levels in the South Central NUCA system of care, how is decision-making power shared between the health system and community? And could you give some examples of that?
Yes, thank you, Zach. I would love to share some specific examples. With over 50% of our employees come from the community and are Alaska Native or American Indian. We have lots of opportunities for voice in decision making, but a specific example I'd like to share is even how we hear the voice of the customer. We get customer input. So, for example, we were sending out surveys on satisfaction from customers, and it was taking a long time to get them mailed back and get actionable data. So an example of, we did a PDSA of creating our own customer engagement survey on an iPad that we would hand to customers after they were seen in the primary care clinics. And we piloted it. We had a pilot and a PDSA associated with that. And we have an annual gathering where we share, it's like a health fair. We brought that iPad. We heard from the community saying, would you like to get a survey like this? We asked elders from the community to try to fill it out to see if it's easy for them to navigate the iPad so we can get input. From that PDSA, we started to implement a new way to hear the voice of the customer. And as soon as what we heard from the customer is, we fill out the survey, but if I don't like something, there's no place where I can share that information. So in the survey, we created a process that allowed for, if somebody was neutral or not satisfied, that an automatic pop-up would come up to say, please tell us why you're not satisfied. And we were able to get data by provider, by clinic, and be able to get actionable data that we can make changes for. That's one example of just how we listen to community. Others examples would be even connected to what our badge looks like, right? So we wanted to change the way our badge looks like with our logo. And it was important that we got input on being able from our community. So we mocked up what our employee badges look like, put them in the waiting rooms of our clinic, and had community who were being seen saying, which one do you like? They wanted the name, first name and last name of the person that they were seeing, and they wanted to know if they were an MD or a physician. And so we got good feedback. Is a little simple thing is what our badges look like, as well as our bigger projects on how we're going to hear voice of community, for example. Thank you.
Thanks, Karen. That's great examples of things that are probably often overlooked, but essential to that patient interaction. So Whitney, the Camden Coalition has a community advisory committee that you helped to build, and one of its functions is to advise the board of trustees. Can you talk about a time when that advisory model really worked, and when you felt that maybe there were opportunities for more robust power sharing?
Yeah, absolutely. So when I came, so I was a partner as a community organizer, and then I came on to staff at the Camden Coalition. And when I came on to staff, the Community Advisory Council was just a council. So it wasn't yet formally a part of the board. And the staff at the time had worked with the members on really learning kind of some of the principles of community organizing, which was beautiful. But one of the challenges about having an advisory council or committee is that they are still beholden in some ways to the mission and vision of that organization, and their goals are to advise on that mission and vision. And so authentic community organizing really is it's clear on the other end of that spectrum that was shared earlier, in terms of you really defer to community around what the topics are. And so there were some challenges around what power sharing looked like when it was in that state, because the committee identified issues around trauma in youth, and the Camden Coalition wasn't necessarily focused on that at the time and was really trying to figure out how to be open and allow, and work with the committee on that. But it eventually felt just kind of like an ad hoc thing. And so we worked to essentially figure out how to more align both the rhythms of the organization and the committee and the leadership, and even think about our participants. So for example, we said, partly why this was the topic that came up is that we really don't have any representation on the council of our participants or graduates or people who have actually participated in any of our programming. So we did a really concerted effort to work with our care teams, to work with our other programs, faith and prevention, to say, are there people who are, at a place where they've graduated from the care intervention and would be interested in staying engaged through our community advisory committee. And we started doing warm handoffs. We would go meet patients with or participants with the person they already had an established relationship with in order to meet them, introduce what we were doing, and invite them into the committee. That really helped kind of shift the makeup of our committee to include, we weren't exclusive to participants, like we would still include other community members, but it helped create a little bit more of a connectedness around what the committee was interested, or what the organization was interested in. And then we also had a new executive director who came from a background in board governance and really understood the importance of creating actual governance seats, that this wasn't just a council that was going to sign off on things that were already done or decided, or give a piece of feedback, that we truly then integrated a system by which the committee elected their leadership. Those two people then had seats on our board. And then we aligned the rhythms of organizational planning, and actually we learned some of this from a visit to NUCA. So thank you, Karen, for sharing your processes with us, but aligned the fact that we would do annual goals planning and make sure that we would bring those to the committee in the early stages, do exercises with them, bring that back to the board and to staff who was doing strategic planning and annual goals setting, bring the final version back, think with the committee about what are our focuses for the next year based on these goals and your interests. And so it was really that helped with the power sharing to truly be collaborative around the goals of the organization. And then we just saw so much more participation and interest in, they became ambassadors in the community in a way that we hadn't seen before. So I would say when you align your power structures, your decision-making structures, and when you are intentional about building that committee, that's really when power sharing is most effective.
Yes, well said. Having those literal seats at the table can definitely make a huge difference. So Dan, what role do you think that hiring and workforce development plays in building accountable partnerships between health systems and community?
At first blush, this question can seem like a bit of a non sequitur for the topic. How do we go from community development to workforce development? And what does this have to do with healthcare? But I got to tell you, in our experience here, Workforce Development Initiative has really become one of the most important tools for our ability to address community needs, our own needs, and really transform the nature of our workforce. Let me give you a little bit of a behind the scenes view of what's happening here. We know from a public health standpoint that income and health status are directly correlated. The higher your income, the more likely it is that you are to report good or excellent health, according to most every survey that's ever been published. And so if we're going to try to improve health status, then trying to increase the income may be one effective intervention for those communities and for our memberships and our patient. We also know, and we may be unique at UPMC, I don't know, we've got a little bit of a workforce challenge right now, a huge shortage. And I see some head nod from the other panelists on the video here. I don't think this is unique to us. Maybe the size of it is unique. And just a couple of months ago, I was kind of taken aback to learn that of the 95,000 employees we have in the UPMC health system, we had 12,000 vacancies in one particular time. And so our ability to deliver safe care, to deliver our care management services to perform as a healthcare system is really in jeopardy with today's world. It is rather shocking. And so we have, on the one hand, the opportunities to improve income and wealth. At the University of Pittsburgh, or the UPMC system I'm a part of, we long ago set the $15 an hour and minimum wage as a goal for us, despite the minimum wage requirements in Pennsylvania. We've just recently, within the past couple of weeks, say, hey, guess what, everybody, we're going to $18 an hour by 2025. We're really trying to reinvest in our workforce and make UPMC a more attractive thing. But to still have, 12,000 vacancies in a month, we went back to our community partner friends and said, help us understand what we're doing wrong. And while we didn't do the formal surveying that Karen discussed, which is incredibly invaluable, we just picked up the phones with some of our trusted colleagues in the community and say, can you help us figure out what's going on here? The response was, Swayze, have you tried to apply for a position at UPMC? Like, you need to get on the web and go through this. And I don't know whether anybody else has had this experience, but you ask a bunch of questions and then you ask us to upload the resume, which has answers to all the questions that you've already asked us to enter. And that's assuming that we have web to get onto the application process itself. And oh, by the way, there's a whole population of people that we in our community organizations interact with who have self-selected out of the process. And it's because they don't believe, based on their history, that you will hire them. They don't have the academic credentials that you look for. They have some involvement with the criminal justice system. Basically, they can't take the time to go through this. And so what we learned very quickly in those discussions was, we're all familiar with the social determinants of health. Well, let me tell you, those same social determinants also impact employment and education opportunities. And so we really had to redesign our entire workforce investment strategy and workforce development strategy to be more inclusive of ways to get these marginalized people, as Karen alluded to. There are people out there who don't have a voice at the table, and it's through these relationships that we've been able to find and change the way that we onboard employees at UPMC, to the point now where we work, we've heavily invested in our training opportunity to say, if your experience in high school wasn't the best and you don't have a college education, that's okay. We got a lot of positions here that we could still use folks like you, and let us reintroduce you and do a very gentle but incredibly supportive learning environment so that you can learn these skills while you're dealing with the homelessness and food insecurity issues and the child care issues that you have, that we understand really make it difficult to transition back into an employment opportunity for you. We have also learned, thanks to that those community-based organizations that both Whitney and Karen were talking about really have access to a population of people that we don't normally talk to. We might see them in the emergency department, but that's not the time to offer them a job, right? We're really focused on what it is they're being treated for at that time. But these community organizations are seeing them in their community meetings, at the food pantries, and all of the different services that they engage with folks. And so introducing the context there and really helping the community-based organization facilitate that initial conversation with a future employment candidate for us has been an incredibly remarkable experience. So much so that we've seen this resonate just with every audience that we've talked to on governmental programs. We're seeing more investments from workforce investment boards who want to pour more money into our workforce development. We are the largest employer in Pennsylvania, or one of the largest employers. So there's a huge opportunity, I think, for us to have an impact on community health and to help address the community's needs to increase their household income and their income of each of their residents there. So this really has, I think, a great opportunity to resonate, an opportunity for us to both help ourselves and address some of these critical workforce shortages that we have, but also to raise up a community in general in the process.
Great, thanks, Dan. So Karen, I think the NUCA system of care is, definitely unique, and it might not be easily replicable in other systems. But what are some concrete actions that you think other health systems could take to start becoming more accountable to the communities they serve?
Thank you for the question. I think that the NUCA system of care can be replicable, in many different areas. I think
Are you back with us, Karen?
I'm back. Sorry about that. Here at South Central Foundation, I think that what we have done and that what other healthcare organizations can do is be transparent about what's not going right. Right. So hear from your community, share, we've heard you, this is what you've said, and have ways to respond to that, to say, we heard you and this is what we're going to do about it. So I think that South Central Foundation success has been having a systematic process to hear from community and to address those things where we're not meeting the needs of the community, being transparent to say we're working on it, and please take time and say this is what we heard you want in your healthcare, and this is what you'd like, and this is what we're going to do about it, and then take time to celebrate with community when you meet those goals. And that's something that has built trust over time for us to continue making improvements to meet the needs of the community, because the needs of the community are always going to change, and there's always opportunities for improvement. So building in your healthcare system a way to hear on a systematic process, integrate those into your strategic planning, and to take action on those items to build trust with the community.
Thanks, Karen. I think all of you have spoken to the fact that people within health systems and positions of leadership need to have a certain sense of humility and acknowledging what isn't going well, as you said, Karen, whether that's our application is too onerous and complicated to apply for a job within the health system, or we feel like we don't really have a voice on this committee. Just acknowledging that things can always be improving is definitely something that we heard in our interviews and that you've all spoken to today. So thanks, Karen. Whitney, in your work now as a consultant, how do you prepare health systems who are used to moving quickly or based on tight deadlines associated with grants or funding? How do you prepare them for the time that it takes to build relationships with community partners? How do you help them build out a plan that incorporates accountability?
Yeah, I think I'll draw on what my fellow panelists have really already spoken to, but you can't wait until there's an opportunity in which you need community input to start building those relationships. And you have to invest in them as long-term and not transactional. And so the way that, the fact that Dan was able to pick up the phone and already had community-based organizations on which he could ask these questions when they came up, that's a testament to the fact that they already had relationship with the community. And Karen's point around building trust, that is so near and dear to my heart, just because you cannot do community engagement work, community organizing, any of that, if your whole system doesn't have a brand of trust. If one person hurts that trust, whether it's your front office staff and the way that they answer the telephone, whether it's the physician that interacts with someone, that memory holds so tightly to a patient's experience that really it takes the whole system to build that trust, and it needs to be ongoing. And so I encourage folks to think about right now, who are the people that you want to and need to be in relationship with, because it's not a health system's core capability to build just relationships for the sake of relationships. Community organizers, our goals were like 20 one-to-ones a week for the sake of knowing people's stories, for the sake of that's not while the doctors and folks are doing something similar, they're often very clinically focused, and my care teams were often surprised how much I would know about a patient's story after just one conversation with them than they knew from multiple visits, just because the focus of our conversations and the intent was different. And so I would say starting with who are the organizations that have those kind of relationships, who are already, that's their purpose and their goal, and how do I have relationship with them? So don't make it my job to do the community-based organization's job, but how do I be in relationship with them, and how do I build trust with them? And a lot of times that's just showing up. That's like, do they have a public meeting in which it's important for them to have diverse power people at the table, and you can be one of those people? Is that just if someone's having a fundraising event and you show up and you truly engage and listen and meet people? The more often they see people representing your organization out in the community in a non-transactional way, the easier it will be when you pick up the phone and say, hey, I have a tight deadline. I really want your input. They're willing to respond. They're willing to work with you. And then once you have that established, the more you can work, as I talked about how Karen's organization has modeled, can you think about how your processes and your rhythms could integrate community involvement sooner? Is there a time in which your organization evaluates opportunities for the next year, or does budgeting for the next year, that you could build in community input there? Is there a time where it makes sense to check your priorities with the community before you decide how you're going to allocate your funds for that year? So that would be my 2 cents: is long-term, start now and make them, and then think about how you integrate those folks into your regular processes.
Thanks, Whitney. I think that's a really great takeaway for everyone on this call. And we often talk about health systems as like this abstract entity, but they are made up of people. And so no matter what role you play within the health system, I think everyone on this call has an opportunity to think about how they can be in relationship with their neighbors and be a member of their community. And that goes a long way to making those investments for relationship building. All right, so final question that is pre-planned, and I'm seeing a lot of questions in the Q&A coming through. But Dan, what is one operational decision point that you think health systems might consider starting with when thinking about sharing decision-making power with the community?
Fly to Alaska or hire Whitney. Either option, I think, would be a good first step for any organization to do. It's a pretty incredible listening to Whitney's description, and Zach, your discussion about humility, just how much it resonates with our experience here. So as Whitney mentioned, I could pick up the phone to a couple of our partners and ask them what we're doing wrong. Well, that's not the first time that conversation has happened. The first time it happened was a very humbling experience. It was after that report was published that said Pittsburgh stinks when it's among the worst in the country when it comes to health disparities. And so I, as a 25-year veteran of UPMC, I've seen people survive traumatic injuries here that statistically should have died, right? I have seen miracles happen with the innovation that we have on the medical front. I have a large degree of well-earned pride in the quality of the healthcare system that we have and the quality of the healthcare that we delivered. And here I am faced with this report that throws all of that out of the window and said, that may be good. You may be on US News and World Report for years and year after year, decades on their honor roll, all this, but you stink. Like, you're terrible at this stuff, Dan. And so when you have to explain that to the community and say, help us reconcile this, like, these things in my head really don't match. And for those partners that are now close friends of mine to say, Dan, you got to understand, you treat every interaction in the community like it's a trip to the doctor's office. When a doctor steps into a room, you're the expert in the room. You know what's going to happen next. You're going to tell and we're tired of that. Like, you come in treating us like we're broken and you're going to be here to fix us. Or you have a research project and you want data out of us and then we never hear from you again. Like, we're tired of this one-way interaction where you come in as a subject matter expert and pretend just don't come anymore. We're tired of this. And so really sitting down and say, wow, we are out of our league here. We may be a world-class healthcare facility, and we are, but oh my God, do we have a lot to learn about this community health stuff. And so sitting down, having those very candid conversations, which cannot occur if your relationship is transactional. If you come to the table, and I know it, I see it in their eyes when I meet with the CFO of a community-based organization, as soon as I walk through the door, they're hearing cha-ching, here's the health insurance guy, and if I could just get him to pay me more, I'll be able to extend my mission and hire more people and do more good. I get that, I really do, and there's a role for that type of relationship as well. But if that's the foundation of your relationship, like, hey, I need you guys to help me find these people, or I need you guys to help me do care management services for these folks, and I'm gonna create a contract, and we are gonna pay you for this type of stuff. But if you don't meet the contractual obligations, we're gonna terminate the services agreement, and we're not gonna pay you anymore. We're gonna really put you under scrutiny for delivering on the things that you're contractually obligated to. Or on the back end from the CFO side, where they say, hey, we got into this, we didn't know what we were doing then, and you're not paying us enough for what you're asking us to do. And when that comes, even though financially they see that as the most sustainable type of relationship, and there's a lot of credence to that, if that's the sole foundation for your relationship as a healthcare system with those community-based organizations, my experience is that's the least sustainable. It's just not going to last. They're going to find an excuse to bail on that contract. You're going to find an excuse to term that contract. And so you really have to do what Whitney suggested. Sit down with them, have a cup of coffee. From my perspective is, tell me more about what you do. Like, I am so amazed every time I sit down with a new community organization to say, you started this with what? Like, this was some idea you had on a weekend and you're funding this by yourself, and you've grown this into, like, you got 10 employees. Not like, how did you do that? That's crazy. Social entrepreneurship is just a fascination of mine, and one that you see time after time and time again with these community-based organizations. And if you don't come to it with that level of interest and intrigue and fascination with what they have done in their communities or who they are as an individual, then I think you're really going to struggle to develop the long-standing, deep relationship that Whitney has when she can pick up the phone and talk to her friends, or Karen has in the same communities that she serves. That's the most important piece. And you're right, it is the hardest one to get healthcare systems head wrapped around. But guess what? It's the same way they interact with their doctors. You don't dismiss doctors easily for most systems. They invest in provider networks. They have a whole host of folks that do this. We just need to bring that same network development mentality to community-based organizations. I'll finish by saying none of this is easy. And as we pilot new programs, I am very candid. And one of my favorite lines to tell them is like, look, this is the first time that we've done this, but if you believe at all in quality improvement, then you know the first time is the worst time. Like, we're going to learn things that we never predicted. We're going to have to go through messiness. There's going to be frustration on both of our parts because nobody's ever done this before. And we just have to have the grace and patience with each other to really navigate through all these lessons we're about to learn together. But I guarantee you it's not going to go smooth. And when you come out of the gate with that kind of understanding together that we're going to be in this for the long haul, we really are committed to making sure that this works, that changes the whole tenor of the conversation and gets you away from just that episodic transactional based interaction.
Yeah, well said, Dan. I think everyone could use more grace and patience in our society, and especially in this context of trying to build accountability. So we do have a couple minutes. Just wanted to give, before we move on to the Q&A, just wanted to give any of the panelists a chance to mention anything that they didn't get the chance to quite yet, or we can start moving on to the questions.
I just want to lift up, and like it's been said, but to be like really lift up what South Central Foundation and UPMC are doing in the way that the community accountability is not just around the delivery of care, it's hiring local folks, it's thinking with them about what challenge, why we're having these shortages. It's not only asking, how was your patient experience during that one visit? And I think that's an opportunity that health systems have in terms of, I mean, to your procurement and sourcing. When you have a board meeting, who are you having cater your meal? Is it a local mom and pop, business, or is it Panera? Is it, there's just so many opportunities to make choices that connect with your local community that are not limited to patient care. And I think I think both of these systems look that up, and I just wanted to highlight that.
Thanks, Whitney. All right, so now I'm gonna turn it back to Hadley, who has been filtering some of the questions from the Q&A, and she'll, forward them on to our panelists.
Thank you, Zach, and thank you to all of our panelists for this rich discussion. So now we're going to share some audience questions. Thanks for submitting these during the session so far. As a reminder, you can submit a question by clicking on the Q&A icon located at the bottom of the screen. But to get us going, Karen, I'm going to direct a question to you. This question is about trauma-informed care. It says, Karen, you've used many trauma-informed care pillars. Has South Central Foundation engaged in trauma-informed care transformation? And if so, how has that informed your processes?
Thank you for that question. Yes, so part of the Alaska Native history in our community has been filled with trauma for generations on how we've, just been in our community. So as part of our approach is to have an onboarding process where we teach a little bit about Alaska history, the history of Alaska Natives in our community, but really it's an opportunity. It's a 3-day mandatory training for all employees that are led by our leadership team, where they learn to share story and receive story to meet people where they're at. So no matter where you're at in your healthcare journey, the expectation is that we're meeting people where they're at in the moment, and we give tools for communication, sharing story, and responding to story is part of how we deliver care, whether that be in our behavioral health clinics or in our dental clinics or in our primary care clinics here on campus. So all employees have an opportunity to know the importance of relationship within our system and to be able to engage community in a way that it comes from listening to stories from their heart and connecting with those.
Great to hear. Thank you, Karen. Dan, I'm going to direct the next question to you. You've generously, fielded some questions so far about, the financing behind this kind of work. And this question pertains to that as well. It says, do you believe a population-based payment system will incentivize healthcare organizations to engage better with community, or just make them angry?
Well, given the history of value-based, I think equal chances there for either outcome. I don't think you can get to a truly value-based healthcare arrangements that's fair to providers unless you include some of their ability to address some of these other community-based issues. There's one study that I'm going to fail to remember the exact reference for, but they pointed to how healthcare provider burnout in a practice was directly associated with that practice's self-perceived ability to deal with social determinant issues of their patient population. And so I think we are asking so much of our providers right now to room patients, that they don't have the staff that used to be able to room themselves. They're on the front lines of this healthcare shortage crisis, and to keep piling on to that all of these other expectations about their role in all of this, without giving them the support services, without making those introductions to those community-based organizations, I think that is likely to just further anger and burn out the provider network. So I think moving forward, all of these community-based initiatives are going to be instrumental in creating a really sustainable value-based care model.
Thank you, Dan. And Whitney, I want to direct a question to you related to power differentials. So this question asks, how do you address power differentials and access to information or knowledge when engaging community and with more technical or wonky processes and changes?
Yeah, great question. something that's really important to me and my team that I worked with at the Camden Coalition is that we don't tokenize community by putting them into positions where they are not supported to actively engage and participate. And so that means both doing some initial conversations with folks and acknowledging not everybody's desire to engage in leadership is going to look like sitting on a committee or something of the like, but make sure that where they're at and what they want to learn is related to the opportunity you're putting in front of them, and then walking with them. And so that looks different for each person and where they're at in their own leadership development. But it means, when I worked alongside a community resident who filled a seat on the board prior to the shifting of the arrangement, we would meet ahead of time. We would review the agenda. So this is one key action that folks in terms of diversity, equity, inclusion should take into account is part of that information sharing requires preparation, and last minute stuff is exactly what will continue to create that power differential, because you're not sending out agendas, you're not sending out materials for folks to review in advance, means they can't come prepared to actively engage. So when that is done, I could sit with someone and we could go over it together. They could ask me questions about acronyms that they saw. We could talk through what questions, like get their kind of prime the pump for what questions might they have for that meeting, so that when they showed up, they felt prepared and ready to engage. When you show up and have less context for some of that language and questions, it's hard to keep up with what's happening, and then you really can't show up effectively. And then it really does feel tokenizing because you're just really filling a seat. You're not actually getting to be a part of the committee. So I would say one of the biggest things is preparation and making sure that your processes include information sharing ahead of time. And then if you can dedicate staff people to supporting folks, at least get acclimated. Some will need that sort of support long term, but at least in the beginning to walk through and debrief with people is another way to do that.
Those are some great strategies. Thanks for sharing that. The next question I'm going to direct towards Dan it relates to sort of fear of change in health systems. So this one is one that we have in the chat, but it's also related to a question that was sent to us at the time of registration. And it says, how do we eliminate health system leaders' fear of change, such as fears about being told that they've done something wrong or feedback that can activate their sense of defensiveness? How do we deal with their fear that they're giving up power by engaging with community?
Wow, that's a fascinating question, coming from a guy who works in an institution that is steeped in tradition. Very proud of the legacy work that we have built on. And I think it's a combination of fear and pride, and just to your point and to the question's point, there is the natural reaction is to defend what you have spent so much time building. You are so proud of the work that you have and what you've accomplished, and to really be able to mentally hold these two things in your head at the same time is really hard. You're good at this stuff and you're bad at this stuff. It's a really difficult concept for many of us to wrap our heads around. I can tell you that it takes some champions internally who are willing to say, this isn't good enough. We should be proud of what we accomplished, but we have so far to go in so many of these other aspects of our care delivery system, and we cannot rest on our laurels. We have to advocate for the people that don't have a voice. We have to look for opportunities to change, even though those opportunities may not be apparent in our data. We need that feedback from the communities. And when you have that type of leadership that's willing to call those things into question, it helps other folks come along, but it also takes a champion leader to really have that conversation start. And then you need to back that up with a bunch of people that are completely transparent in their flaws to say, yeah, we have messed this up. And if you walk into those meetings that we've all talked about, trying to defend the history, what you're going to find is there's no opportunity then for change, because they're not going to perceive that in you. But when you change your approach to those communities and say, I know we've messed up. I know we're not doing good enough. I know we can at least do much better in this space. It changes the nature of the conversation. And that has resonated all the way up to our board now, where some of those community partners that have originally given us the most candid and difficult to swallow feedback on our performance now sit on our board. We've given them the power to say, help us change this. Like, we need your leadership at the topmost level to make sure that we don't continue to perpetuate the mistakes that we've made in the past.
That's really a powerful example to hear. Thank you, Dan. Now, Karen, I wanted to direct a question about rural communities to you. So this one says, we all know about health inequity and speak about it all the time. How can those in the small, poor rural communities make steps that are measurable to address this issue of community partnership with health systems?
Very good question. So in addition to, serving here in the biggest city, Anchorage, Alaska, we also have community health centers in rural Alaska, and we serve over 55 different tribes in those rural communities. And what we've chosen to do is, again, be transparent and listen. So we've created community advisory boards that help inform services that are provided in those rural communities. For example, my dad's family is from the Pribilof Islands. That is St. Paul Island, where we have a community health center there, and we partner with the tribe and we share with them what the budget is. We're transparent with, these are the services that we can provide with this type of funding, and then we meet with them on a regular basis to see how we're doing, what we're doing. And in addition, if the community wants more chiropractic care, we have conversations openly about, if we have more chiropractic care in St. Paul, for example, then that may mean that care provided there for optometry or for dental, we allow for co-creation of the services provided in that community by having engaged the community in what they'd like for services. And we've done that historically with all of our community health centers, and created community representation to say what they want, how they want it, so we could provide services that meet their needs.
It's fantastic to learn about. Thank you, Karen. Next question I'm going to pose to Whitney. And this one I think is an interesting one. It came up in our interviews for this project about, if I'm reading the question correctly, about the sort of risk of reputation that some community leaders inevitably do when they engage with large health systems in their community. So this question reads, and I'm going to paraphrase it a little bit: advancing health equity is a political act. Sometime community champions engage with health systems and can put their reputations at risk. How do we support them when they are trying to be insider advocates while still being champions in the community? And how do we navigate the political landscape where we're not just delivering health system management what they want versus what it is that the community wants?
Just an easy question to round out the day. Yeah, that is a tough one. We often talk about, in the ecosystem of social change, the importance of inside and outside strategy, and knowing that there is a time and place for outside community voice that can push without any, I worked for community organizations that said they would never take government funding so that they could always hold government accountable without fear of losing funding or upsetting the hand that feeds them. And then I've also seen community residents who felt like when a community resident was invited to actually sit on a board, it was a way of silencing them. So there is that fear out there in terms of if I become part of the system, I can no longer truthfully and honestly speak my piece because in some ways I am a part of it now. And I think that what is important is helping the community that that person is a part of. One, understand that their role within the ecosystem has shifted. They haven't left it, but they have a different role. And that if we can stay close to one another, it can still be a collaborative approach. It can still be knowing that I'm close to my home community. I know what our needs are. I'm going to do my best to advocate. And I may only be a messenger or only an advocate. I'm not a decision maker. So another important piece of community leadership development that we often did is around decision making and power, and who has the power to change which decisions. And then how do we build power to have a conversation with and impact that decision maker's challenge. And so it's just helpful. It's a larger, kind of broader conversation. I don't know in terms of supporting the person who's inside. I'm not sure if I have as much advice on that. I'd be curious. I'm sure, Karen, you probably have folks actually, you both probably have folks within your system who are community residents who are seeing things and who are being advocates. And I have seen folks within our organization who feel burnt out and unsupported when they try to advocate within systems. So I would be curious if you all even have a response to how you support that.
I'll defer to Karen to go first.
Oh, thank you, Dan. So we have opportunities for our leadership to be on other boards and be in the community, right? So inside, we support, because we're remote, even in Anchorage, the biggest city, we tend to collaborate, for instance, with other hospitals, other communities around healthcare issues. So, we partner with advisory councils in the community, and we represent South Central Foundation and the needs of our community outside of just our healthcare system. And that's one way where we've had opportunities to think about the greater community and healthcare issues and how we can support them inside our organization, but also, as a large organization or a larger community outside just Alaska Native healthcare. In addition to that, inside advocates, our system is unique because over 50% of our employees come from community. So I often hear from my aunts and uncles all the things that need to change in the system, and have voice to that through our committee structure and our strategic planning process.
I'll just add, in both cases, it seems to me that our role, if we really want to enable the transformation that I think we all seek, we have to find a way to make sure that the communities that we're trying to help have an equal voice in each of those conversations, and that their relationship with us and our relationship with them has got to be dynamic. It cannot be we're arm in arm together all the time, when in fact they need us to play a backstage role. Like, you have the data that I need access to do this, but I don't want you talking about this in public, because that's just going to ruin my attempt to make transformation happen in the communities that I'm trying to serve. And you being comfortable with that. You also, for the folks internally, saying, look, I realize that the dynamics of a board meeting may be such that there's a lot of agenda items to get through, and that you may have wanted to prioritize a particular topic. So if you don't have a chance to vocalize that internally, bring that back to us afterwards, or send an email to the CEO and say, hey, we didn't have a chance to talk about this, but I'm curious. And then following up and responding to those kind of inquiries, and making sure that if that particular venue doesn't have an opportunity to raise that issue, that the community still has a voice in that, and that we still take action in it, and then follow up with that in the past. So I think we just have to be prepared to transform the way that we interact with the community, is the bottom line. Sometimes we're going to be on stage with them. Sometimes we need to be backstage. Sometimes we need to be the target of their venom, and just realize that if they really are going to be effective at making change, that we need to point the finger at them and say, we're part of the problem and we need to fix it. Because sometimes that's the easiest way for us to make the transformation happen in our own organizations.
Thank you, Dan. Thank you, Karen. Thank you, Whitney, so much for sharing your work, your passion, your insights today. We really appreciate it. With our final seconds remaining, we were going to just share the slides very briefly to let you know that we have some upcoming events that you might be interested in that are related to this topic. First, on February 28th, we're hosting a webinar on lessons learned from Denver Health on advancing trauma-informed health systems. And we'll also be releasing our brief about everything we discussed today about this project later this month. So please look out for that. On the next slide, you can learn more about how to connect with us through our website, chcs.org, where you can subscribe to our email updates and follow us on Twitter. And finally, last slide, just a big thank you again to our panelists and to Zach for facilitating the panel. And thank you to everyone for submitting your questions. You'll receive an email with the recording and the slides. Feel free to share those, and thanks in advance for completing the survey that will pop up on your screen momentarily. Have a great rest of your day. Thank you.